health checks, lung health checks. Thank you. And maybe we could even say that we should go in towards lung health checks. I'll come back to that. Let's see. Oh, how do I? Oh, yeah, good. Yeah, so far so good. Sound?
Yep,
good.
It's good.
Thanks. That's
Thank
good.
you.
Thanks. Good. That's good. I'm going to, yeah, no, that's fine. So let's say two things. In Europe, it's clear cut. We want to know whether it's effective, whether the benefits outweigh harms and cost effectiveness. And only then we would introduce a new screening program, a new cancer screening program. To some extent, it's the same in the US, but probably cost effectiveness is a bit less on the agenda maybe. And so we are to some extent proud that actually the US Senate had a resolution that says we should promote efforts to increase awareness of and education about lung cancer and lung cancer screening among individuals and encourage the people to observe the Lung Cancer Awareness Month with appropriate awareness and educational activities. So to some extent, there is certainly some difference in how to approach a new program. But anyhow, benefits outweigh harms and cost effectiveness, we actually also do know now. So true, this year, fortunately, we published in the New England Journal our Nelson trial. I will go through that. You, of course, could have read it. You may have read it already, but I will walk you through some major ones, but then really go towards the future also. So our Nelson trial was actually of about 16,000 people. They voluntarily participated in the study, and most of them were males, 85% or so. Why? Simply because at that point in time, when we started the trial around 2000, the prevalence of smoking in women was simply quite different, quite much lower. And so we had to recruit many more women in order to get enough women into the trial. And we didn't have the money for that. So at that point in time, we thought, well, if we get an answer for the males, that would probably also the correct answer for the females. Why not? Now we know a bit differently, but that's simply how it started off. Roughly, we just randomized them into two groups, one a screening group, another one, no screening at all. Usual care if you have symptoms, but nothing else. And then in the screening group, we had a baseline scan, a scan after 1 year, a scan after 2 years, and another scan after 2.5 years. And so in fact, that we are the only trial with different screening intervals. And that gives us a lot of information actually. What I'm doing. Sorry. Yep. Oh. Are you still seeing me and my slides also or not? Are you still?
We still see you. The slide says Nelson trial and 15,792 people voluntarily participated in the study.
Yeah. But I can't see my slide now, which is, I should resume share, I guess. Yeah, thank you very much. Apologies, I did something wrongly.
No problem.
Yeah, so I couldn't see my own slides. That's not easy. So the next one, in the screening arm, actually, we only referred about 2.1% for further assessment. So we did screens and only 2.1% we said this is suspicious for lung cancer. That's a huge difference compared to the other trials. And then in almost half of them, we found lung cancer. So that means a positive predictive value of around 44% or so, 45%. That's very nice because it simply means that the amount of false positives is simply so much lower than in some other trials. These are the results in the New England Journal, table 2 per round. And basically you see here on the bottom of the slide, I think you can't see my cursor, I presume. No, but on the bottom of the slide, you see the total numbers, positive test, 2.1%. So 2.1% suspicious, and almost 1% we found the cancers. We had an indeterminate test result. What is that? That means that we said to the individuals, we see something, probably scar, probably inflammation. We don't know for sure, and please come back in 3-4 months to repeat the scan. So that's an indeterminate test. We did not say suspicious for cancer, only said, please, we want to know whether the nodule is growing. And that means indeed in about 9% we needed an additional scan, but they were not false positives. We didn't say it's suspicious. So here then you see by time what happens to the incidence in the two arms. So lung cancer incidence, if you go from the left to the right-hand side, these are the years since randomization, year 0 till year 10. And of course, unfortunately, in the control group, the number of cases, the number of lung cancers increases. But you see this huge difference in the blue. The blue line is, of course, in the screening group, where we found much more cancer in the earlier years due to the screening program. This change, you need to have that, of course, in order to be effective at the end. On the right-hand side of the figure, you actually see that the difference between the two arms is very limited. So the issue of, are you now going to find a lot of cancer that is ridiculous, that is slowly progressing, overdiagnosis, that is really limited. The two curves, after 10 years or so, they come together basically. This is then the major difference in the stages. On the right-hand side, the control arm, no screening, nothing, usual care, 46% in stage 4, only 13% in stage 1. On the left-hand side, the major difference in the screening arm, only 10% detected in stage 4 and 60%, 60, in stage 1. That's the major difference you make. And especially, of course, in the first 5-6 years when we had the CT scanning going on. And what is then the result? This is then the result on mortality. So again, the same sort of curves, but now, of course, red and blue is the other way around. The control group is on the top. The amount of people dying from lung cancer increases by time in your control arm, but you make this major difference in the screening group. The blue line is below, and the cumulative mortality rate ratio is 0.67. So a 24% difference in the lung cancer mortality between the two arms, and that's statistically significant. So this is our first major result. And here you see, when we look back in year 10 and look back, actually, we already had statistically significant results in year 8 and 9, but we had, of course, anticipated to look in year 10, basically. But again, a clear-cut, stable situation of a huge effect in the males. So then some people say, yeah, that's fine, lung cancer mortality, but what about all-cause mortality? What about the other causes? And here you see, again, by time, figure S for A and B, or figure A is this, I think, in the supplement. You see here by time, there is this, the red curve is all causes, so all mortality in the control arm, and the blue line again is screening. Screening is actually either in the screening arm, is below the red line or almost the same. There's no statistically significant difference between all cause mortality. And so what does that mean? Well, here you see a paper we published in my senior research fellow published in Cancer Medicine, Eveline Heinsdijk. And here you see a bit difficult, but the black bars is the amount of, is the year in which you could find a statistically significant effect on all-cause mortality, given the fact of lung cancer being reduced by 25% or so. But you see the enormous amount of people you need. Here you see you need at least 40,000 people in your trial per arm to be able at some point to find a difference between the two arms. You could do that. You could find such a result earlier, but then you even need larger trials, of course. So on the bottom of the slide, you see, for instance, 500,000. If you have a 1 million trial, we would have found a statistically significant effect, but you need a 1 million trial. It's a waste of resources. You should not do that. It is a waste of resources. You want to find a decrease in lung cancer mortality first, and then the next question is, but is there an increase in other causes of death? And of course, you're going to look at that. So here, table 4 of the New England Journal shows you the differences in other causes of that. For instance, you see here other neoplasms or cardiovascular disease or respiratory disease. And basically, there's no detrimental effect in the screening arm, for instance, that there is more deaths from something else, given the amount of follow-up, given the same amount of person years. So yes, it works. There's no detrimental effect. It is true, if you had looked at the paper, there are actually 2 small groups in which we do find a statistically effect the other way around that we want to have. Actually, in the 2 groups, symptoms, signs, abnormal clinical findings, endocrine, nutritional, metabolic disease. But these are only 87 deaths out of the 1,400, 1,500 deaths. And we know from these 2 groups, there was only 1 person with lung cancer confirmed, but it had been reviewed by the expert committee. So there's no lung cancer death. It had been reviewed. And the other 3 cases were people with a CT scan result, but they died, like, let's say 16 months, at least 16 months later. So again, that doesn't have any clue with the screening or whatsoever. So it works, it reduces lung cancer mortality. There's no detrimental effect. And that we don't see something on all-cause mortality is just a power issue. We are not powered to see that. So I hope I'm still with you, because now the interesting thing is we looked at males because that is our big trials, males, but we did include females. In a later recruitment round, we included a small group, about 2,000 and 2,500 women. And what we actually see now is that in year 7, year 8, year 9, there was a statistically significant effect also in the females. And actually, even bigger, much higher than in the males. The males is already in a very nice effect, but the mortality rate ratios are even bigger in the females. In 3 years in a row, statistically significant. Is it logic? Let's have at least one difficult slide, or maybe you all found some of them already difficult, but nevertheless, this is one based on the NLST trial, the American trial. This is so-called mean preclinical sojourn times. A difficult word for being basically saying how long is the disease already detectable by the CT scanning. Based on the trial data, we can make such an estimate. And actually here you see the different histology, adenocarcinoma, squamous, small cell, other carcinomas. And you see here, if you look at the row that says total mean preclinical duration, it actually says, for instance, in men, it says the 4.48. I hope you can see that in the first sort of column, or the second, I should maybe say. It basically says we think for almost 4.5 years before clinical diagnosis, lung cancer can already be detected by the CT scanning. But the interesting thing is 4.4 year given the adenocarcinoma, but on the bottom of this slide, you see it's actually 6 years in women. So apparently we are even able to find a little bit earlier lung cancer in the women than in the men. And that's probably why we actually find a bigger effect in females. Again, the effect in males is already substantial, of course, but it's interesting to see this gender difference. And actually the NLST, I'll show you in a minute, the NLST also had that, but one way or the other, it didn't focus on it. So here the next slide is the comparison between the Nelson and the NLST. And I chose the year 8 to be able to make the comparison. So here on the left, you see males and females, 0.76, 0.41 in year 8 for Nelson. And the NLST is the big American trial. Again, of course, the first landmark paper. And it shows 0.92 and 0.73. So again, a gender difference, but the result as such, the point estimate is in Nelson even bigger than in the NLST trial. And in the last column, it actually shows the NLST eligibles in our trial. And again, it gives a bigger estimate, a larger point estimate than the NLST. Again, NLST is huge, very instrumental, very helpful. But fortunately, we found that in our trial, you can even have a bigger effect with a low referral rate. That's the big difference, of course, between the NLST and our trial. we can do a bit more stringent referral and then still have this enormous result in lung cancer mortality decrease. So that's all, of course, very good news. So what did we do recently? This is, you are the first to see this slide, actually. What we try to do, and of course it depends on who you are going to invite, but just give you a bit of an example. This is for men who are 60 years old for a trial that we will be running. I will show you in a little bit later on, a little bit what we will do in Europe. On the left-hand side, 1,000 men who are eligible for this trial, but they are not being screened. And on the right-hand side, the same 1,000 men who get screened annually. And then actually out of the 1,000 people on the left-hand side, about 161 would die from lung cancer, but with the screening program, only, let's say, 112. So a difference of 49 people, men not dying from lung cancer anymore in their remaining lifetime if they get screened annually. That's a huge difference in this devastating disease. This is in men, and I think the next one is in women. And actually, here you see, we find on the left-hand side actually a bit more women with lung cancer mortality if they have not been being screened. And on the right-hand side, again, with annual screening, a difference of 87 women not dying from lung cancer. That's our estimate now, based on NLST and of course, a bit given whom you're going to recruit. But just to show you this enormous change that we can make, I think. And so how does this compare? So again, there is a bit of a difference, of course, between Europe and the US, but that's just fine. But here I try to give a sort of comparison between 5 possible programs we could have or we are having in the Netherlands. On the right-hand side, cervical cancer screening with HPV testing. And you see here, sort of in the middle, it says about 250 deaths prevented per year in our country. Just to let you know, we have 17 million people in the Netherlands. So just to, then you can make a sort of estimate for the US yourself. So on the right-hand side, we have a cervical cancer screening program that works, is not so expensive. It leads to a number of deaths prevented. If we would have a prostate cancer screening program, we actually don't have that. There would be about 650 deaths prevented each year. You see, we have a breast program. We would then find about 1,000 deaths prevented from breast cancer each year, and probably going to increase a little bit more. But there is the comparison with lung. If we would have a lung program now in the Netherlands, we think we could at least at some point in time have 1,500 to 2,500 lung cancer deaths prevented per year. That's the comparison you at least want to make. And that's maybe in the order of colorectal cancer screening, which is of course two sexes, where we think in the Netherlands we would have like 2,000 or more deaths prevented per year if it's in a stable situation. So this is I think a very interesting comparison, but actually to show you that the benefits can be huge given what we know now from lung cancer trials. So we also did cost effectiveness analysis. Again, that's quite needed in Europe. Without such an analysis, many governments would say no to a program. That's certainly a European thing. I think it's fine myself, but that's how I'm educated, of course. But just to give you a guess, on the top it says for Canada, we did an analysis that says, well, maybe you can have a cost-effective program that is about 40,000 Canadian dollar per life year gained. We did an analysis for Switzerland, maybe 40,000 euros per life year gained. And we did analysis published a year ago or so that says, well, maybe between 50 and 100,000 US dollars per life year gained, which actually means it can be actually also cost-effective. It works, the harms, the benefits outweigh the harms, and it can be cost-effective. So that's let's say the amount of information we have now. And so I would like to sort of end with a couple of things for the future. I think I still have quite a couple of slides, so let's see where we are. But one important thing is this screening interval. Given the rapid growth of lung cancer, you would normally say we need annual screening. You need annual screens in order to pick up enough people every time. But it is possible and likely that if your first scan is negative, then maybe your chances for lung cancer in the next couple of years is really limited or is really less than if your scan is not negative. So it's possible that maybe if your baseline scan is negative, you could do with a longer interval. But you want to know whether that's safe enough. So that's actually something we're going to do in a European trial. But just to give you a bit of the idea why, here again, the men on the left-hand side, you have those situations with annual screens. So on the top are the lung cancer deaths and the difference we have seen beforehand. But now there is a sort of, I think it's a sort of pink red or so, shows you the number of people that need a biopsy or a bronchoscopy that are ultimately not lung cancer. So they have an invasive procedure, which is unfortunately at the end benign. Well, fortunately for them, but it is an invasive procedure. If we would go into a risk-based screening interval, the right-hand side shows you that maybe about half of these invasive procedures can be saved. So because you simply need less screens, less false positives, less invasive procedures. So that is why I think it's really interesting to see whether it's safe enough to change your screening interval. And that's really new. So it's called 4 in the long run. I'm the PI of the trial. It's European money. And we hope to get implemented in different European countries and basically show you this, whether it's safe enough to do a different screening interval if your baseline scan is negative. So not to show whether on mortality, of course, we know it works. This is just to show whether at the end the stage shift is still quite reasonable. So this is the details. We need about 24,000 people for that. Again, it's actually about implementing screening, of course, in these countries. It's not about postponing. It's actually about implementing lung cancer screening, and then with some sort of remaining research questions to be answered. The other thing is, of course, whom to recruit. Initially, people said, well, we could use a sort of risk calculator. Here on the right-hand side, you see sort of, what is it, 2, 4, 6, sort of 10 questions. You can go online, fill them in, and then you actually know your risk for lung cancer, if you fill them in correctly, of course, for the next 6 years or so. And you could say, well, if my risk is 1.5% or more, I probably should have a screen. Initially, people said 1.5. That was based on the NLST trial. We now basically know that 1.8 is probably as safe enough. And maybe we should go to 2 or 2.5 in Europe. Well, we sort of don't know exactly what the correct cutoff is. But you can imagine that if you are below that risk level, it's of course an arbitrary choice, but you could say, well, maybe then benefits do not outweigh harms because you have false positives, you have radiation risk and so on, and your risk is actually not so high. But that's an arbitrary choice, of course, to some extent. There is, to let you know, there's a Yorkshire lung screening trial that tries to, the details is actually, they're going to look at different risk calculators. So here on the left-hand side, it's called the PLCOM risk calculator, or the livable lung risk calculator, or the PEC years that the US Preventive Services Task Force advises, to see what is maybe best in this respect. So that's actually quite a reasonably large trial to look at these different recruitment criteria. There are a couple of other trials. I will not go into much detail of that. They're, again, not to show any more stuff on mortality. We know it works. So this is more about implementation issues. For instance, there's a lung health check in London where they tested invitation materials and all sorts of stuff. They, as you can see here, they call it lung health checks now, not the word lung cancer, actually. It's quite debatable whether you should do that, yes or no. But I'll come back to that in a minute. But the point is, in the UK now, they are going to have like 10 lung health check pilots. And I'll show you here the details, where actually smokers and ever smokers between 55 and 75 with a certain cutoff are being screened now. Unfortunately, of course, due to COVID, it was stopped sort of in the last year or so, but they will start soon again. And they will be one of the big implementation studies in Europe, let's say. Here, just to show you, don't look at the details, but actually it does mean here on the top, these are all English pilots sort of. And if you look correctly, actually the age range and eligibility, they all vary. So apparently we are sort of still, we don't have a fixed cutoff yet to say, well, we should probably do this and that. That has all sorts of reasons, of course, and we can debate on that. Maybe here, again, a full slide, but if you look at the bold line, the bold row, you can see that in many of these trials, many of these pilot projects now, the detection rate is in the order of 2 or 3 or even 4%, so higher than seen in the trials in the NLST and in Nelson actually. But the problem, of course, is you don't know exactly who is coming into your pilot project. So they may be at very high risk, and therefore the detection rate is higher. So we think, unfortunately, in the past, if you had lung cancer, you would have about 200 days left. It is that bad. We think now with lung cancer CT screening, we can add about 12.5 years. If you're not dying from the disease anymore, and even considering comorbidity, this is what you gain. Of course, unfortunately, not everyone, but for those who will not die from lung cancer anymore due to CT scanning, they will gain much and much more than we had. Immunotherapy, of course, we really hope it will work in the future for some, but up till now, we're talking about 100 days or so on average, additional survival gain. I hope I still have like maybe 5 minutes or so. So the very interesting thing also of the CT scanning is that you can do more on the CT scanning. And of course, there are all sorts of ethical issues with that, but one of them really important one is calcium scoring. You can look at the calcium in your coronary arteries to see whether you are at risk for cardiovascular disease. And so calcium scoring, doing it the same way when you do the CT scanning, is probably very, very interesting. These are the other things that we are looking at in our trial. You can look at much and much more, but we probably don't want to do that in Europe. You cannot do everything. You should not do everything, probably. That's what we think. But the calcium scoring is very interesting. And because just to let you know here, of course, we have smokers and ex-smokers. So they are really at risk for cardiovascular disease too. And this is a logistic regression analysis in which actually shows that smoker at baseline, here somewhere in the middle, has an odds ratio of 1.52 for calcium, for a high calcium score. And that is one of the most important categories with family history, of course, and age. But it basically means these smokers and these ex-smokers, they are really at risk for calcium and coronary artery disease. And therefore, maybe we should do that in the same way. There's not much evidence on that. And I'm happy and proud, of course, to say that we are doing a trial on that, where we actually in Europe are doing so-called the Robinska trial, where we want to see whether CT scanning and acting on calcium scoring is effective enough. So that's basically this analysis where, in fact, we compare a group in which you have the classic scoring, the classic cholesterol, blood pressure, versus only look at the calcium score CT. And just to let you know, in red, it basically says what the point is that probably the calcium scoring gives a much better, let's say, redistribution of risk. So maybe we can even need less people to have a treatment, because there may be actually a lot of overdiagnosed, overtreatment according to cholesterol and blood pressure only. But that's, we have to wait a little bit. So this is, I'm going a bit faster now. This is basically the same thing. But the point is, in the next slide, I think it says, we are almost completing 5 years this year. and we need about at least 5 years. So hopefully in the next couple of years, we will know whether this is also effective, just acting on calcium scoring. But again, I would say now if you recruit for CT scanning, probably take this into account. Let's see, next slide. So I think this proud to say that in the US House resolution, the NLST and this other large randomized trial was included. I think this I already had some impact in clinical care and public health, but this is quite nice to see, of course. I think I have a couple of slides, but please, if you say I should stop, let me know. This is, of course, the summary. Lung cancer screening works. On the left-hand side, the NLST. On the right-hand side, the Nelson trial, basically almost showing the same thing, but even bigger reductions in Nelson. It means we can have cost-effective lung cancer screening, which gives actually some more absolute benefits than some of the present screening programs we have. That is quite interesting. Many people probably don't realize that. So you have to make these numbers and to show that to politicians or to individuals. And there's a recent paper, I think, I'm not sure, but I think it's not yet accepted, where we actually are looking whether if you have breast cancer screening, lung cancer screening, cervical cancer screening, and if a person says, well, I want to skip 1 or 2, I don't want to have them all, then the answer basically is, if you are eligible for lung cancer screening, you should not skip the lung cancer screening. 2 more slides, I think, the disclaimer, because the disclaimer is indeed, we have no clue almost about never smokers or Asian population. So fortunately, there are now 2 trials, one recently presented, indeed the Talent trial in Taiwan. Why? Because about half of lung cancer is in never smokers in Asian population, one way or the other. So this is a trial in which, or maybe I should say a pilot, an implementation study, where about 12,000 people have been screened. 3/4 was female. So that's good to realize if you look at numbers and data and results, 74% is female. I already told you, maybe you can advance the diagnosis a bit more in females. So it's likely that you get a bit higher detection rate. And basically what they did is they are recruiting based on either family history in about half of the people, or on passive smoking, tuberculosis, a cooking index, and not using ventilators while cooking. And you have a sort of risk calculator for that too. And now they found a detection rate of about 2.1%. So that's quite reasonable, I think. But good to realize again, their false positive rate is 15%, 1.5. So there's still a lot of work to do, I think. What I know is the last one, I think, is that in Singapore, they would like to start same thing, like about 2,000 people based on PEC years, but maybe 3,000 people based again on family history, secondhand smoke, cooking experience, and cooking without ventilator, to see what it will do in these populations that basically have not been included in the NLST or the Nelson trial. So I think that's what I can tell you. I hope you enjoyed so far, that I was still, you could hear me, I hope. And then I think I'm open to Q&As. I think this was my last, correct? Yeah, and of course, these are all the acknowledgements and disclosures from the last 20 years or so. Again, thank you for inviting me, and happy to start responding to questions if possible.
Fantastic. Thank you so much, Dr. de Koning. That was wonderful. That was a real tour de force and just a great overview, but also a lot of really excellent insight, in-depth insight about lung cancer screening in Europe and also in the world. So I think we have about 21 minutes, which is great. We also have a really diverse audience, which is wonderful. So ranging from general public to college students and medical students, residents, and also faculty at Harvard Medical School. So it's so we have a range of questions. I'm gonna start it off by letting Alex ask the first question, and then we'll get through all the questions in the chat. So.
Wonderful. Thank you so much, Dr. de Koning. That was incredible and super fascinating. I was curious with COVID and lung scarring, do you think that will lead to an increase in suspicious findings in lung cancer screening programs in the coming years? And how should we like address that?
Yeah, that's a very good question. So I think indeed what we see apparently is that we have those ground glass opacities that have correlate that could be lung cancer on the one hand, that it has COVID. What should I say? Prognostic feature. I think it could be sort of useful. So we could use to say, listen up, doing these lung cancer CT scanning is effective for many, many people, can be effective for many, many people. And within this COVID crisis, it may even help us a little bit to see other features or whatever. So it may be, I should probably not say win-win situation, but it's maybe not too bad, if you see what I mean. Is that what you?
Yeah, so that was part of it. I was also wondering, in like, say 5 years from now, once the COVID pandemic is over, hopefully, will we see an increase in suspicious findings because people who are getting screened have more lung scarring and damage?
Yeah. So the easy answer is we don't know, of course. Now, a good point. So I do think that, so there is a big difference between the US and Europe in this, the way to refer. And so what we did in the Nelson trial is we looked three-dimensional in the volume of nodules. And so I think to some extent, that's also the answer to this issue, that if you do that and you have clear-cut criteria to say, well, in this indeterminate situation, we wait a couple of months and see whether it grows, that should be the criteria to do something differently. And then you make the difference between the scar and an inflammation and something else. So maybe it is more reason to use that kind of thing. That's what we also said, what I just said. There are some indeterminate lesions. We said probably a scar, probably inflammation, please wait. So maybe that's the way out.
Wonderful. Thank you so much. Let's see. Dr. Ng, do you have any questions?
No, I'm good. I think we have a lot of questions in the chat, so we're going to get started on those. So we have a question. I don't know if Florian is still here. He's one of our radiologists and professors at MGH. But his question was, do you think the small sample of women in Nelson contributed to the large point estimate of the mortality reduction compared to men? The confidence interval was very high.
Yeah, no, of course, good point. So no, I do think that we had enough power to show the effect of males, and that's the 24% or so, very stable throughout. It's true, we had a small subset of women, initially not even powered for that. We basically said, okay, we want you to have a bit more information on the females. The fact, again, that it's statistically significant in 3 years in a row is to me clear-cut, given all the plausible biological things we know. It's completely, I think, a clear-cut answer that it also works in women to a larger extent, if that's the answer you're asking.
Great, thank you. And then his other question was, what parameters go into the risk assessment for the 4 in the long run study? Yeah,
so there are two. Yeah, so there are two things. We are in principle using this PLCOM risk calculator. So the one that I showed with the 6 to 8 questions, and then probably start off with something like in the order of a 3% risk or more, or something like that. So I'm vague, but I'm just saying that we submitted to say 3.25% and more. We hope to even go a bit less than that now. But the point that does mean we are very stringent. But again, I think to start up stringent in different countries that have to scale up is probably just fine. So it's either 3.25% or possibly the 35 PEC years and the quit smoking in the last 10 years or so.
Yeah. Great. And then our next question is from Anna Isayeva. Anna, are you here? Would you like to ask the question yourself, or?
Yeah, sure. I was just wondering, what would you do if, say, on your low dose CT scan, you found one of the incidental findings, like, metastases that look like they're from a primary lesion, or like the criteria you listed out? And as well, what do you have anything to say about, the possible increased risk for the women that you're screening, given how radiosensitive the breasts are?
Yeah, so the issue is with the let's say with the machinery that we used, it's really low dose CT, and it's really how should I say, focused on what you want to find. So it doesn't mean there is, I think it doesn't mean there's any risk on the breast, for instance, or so. And it's true that we really have to try to make a big distinction between screening for something versus clinical. So it's true we can find anything on these CT scans. There are the Allcause and the international Allcause has published on that. You can find osteoporosis, you can find breast cancer, so all sorts of things. But I think we really have to focus and say, okay, we are going to invite you for lung cancer screening, maybe also for calcium scoring, and only if we find some significant stuff that we really think we should act now, then refer for that. And that was that small list that we think we will use in the long run. And I know that, of course, it for an individual clinician who next day sees a clinical question, it's not so easy. But I think that's the major sort of distinction between inviting people for lung cancer screening and calcium scoring, and basically leave the rest out, if I may say it that way.
Thank you so much.
Great, thank you. And our next question is from Sullivan A. Would you like to ask that question? So Sullivan A's question was, is radon exposure a potential variable for risk-based selection?
I think not. In the sense we did one analysis that has been published where we said how big should the risk from other factors be in order to get the same sort of harm-benefit ratio as the U.S. Preventive Services Task Force agrees upon. And then our answer was actually you should have a risk of about 20 or 25 times the average risk. So, and there's almost no risk factor for that. Maybe radon, maybe us, no, almost. So, and of course you could say, well, that's arbitrary. I find it ethically okay if I have if the harm-benefit ratio is a little bit less than that for these specific subgroups. So you can sort of play around with that. But actually, it's smoking, it's ex-smoking, and indeed for the Asian population there are some other stuff, but I think in Europe and North America not so much.
Great, thank you. And Andrea Kim had a question. Andrea, would you like to ask that?
Yeah, hi, thank you. Thank you so much for your talk. So I'm here in Ireland inquiring about the atmosphere that Ireland has in general about cancer screening programs. This is majorly due to the cervical cancer screening scandal where there were screening errors and false negative test results that were highly publicized. And in such an area like this where implementing cancer screening programs face such significant hurdles and public scrutiny, what would you recommend as alternative means to effectively prevent lung cancer and educate those at higher risk of getting lung cancer?
And what did you mean with the alternative? Alternative instead of screening, you meant, or?
Exactly. Yeah, exactly.
So of course it's clear cut. Primary prevention is on top, or is first, or has to be done in its utmost best to have people not start smoking and people quit smoking, etc. But the issue is simply that there are now so many people that have stopped, for instance, and are at risk for decades now, that we have this alternative. Again, I think, and I know it's not so easy, but again, I hoped with that one table to show you that indeed people have all sorts of arguments about lung cancer screening, of course, and smoking and shooting, well, whatever. And this is different from breast or whatever. I hope to have shown you that actually, if you make the correct calculation, a lung cancer screening can be much more effective than cervical cancer screening, also in Northern Ireland, I presume. Or did I say Ireland? Sorry. And think that is simply crucial. And surely it's a bit more costly because CT scanning is a bit more costly. But with this risk-based interval, we may really going to save money, I think. But the point is, we get much more benefits, and they still have a lot of life years to be gained. So it's not that one should say, well, comorbidity, and these are all smokers and ex-smokers. So the moment we find the lung cancer, a couple of next years, they will die of something else. Yes, there will be those people. But as you saw, maybe we're talking about 12 years, life years gained, even given the comorbidity. So that's huge. Is that what you wanted to hear, or?
Yeah, perfect.
And there's not so unfortunately, there's not so much other alternatives, I think, unfortunately. Yeah.
All right, thank you.
That's a great question, Andrea. And I just wanted to comment, Dr. Koning, many of your slides were fantastic and just directly addresses the kinds of questions we've been getting during our community presentations. And so we might email you afterwards and get some citations for some of those slides. But the next question is from Anna. Anna, do you want to ask your question?
Sure, that'd be amazing. Thank you. So first of all, thank you for the amazing presentation. It was really informative. I guess my question is mainly focused on how we can bridge the gap between research and clinical practice, particularly like what are the best methods to increase the accessibility of lung cancer screening, particularly in minority or impoverished populations.
You mean, for instance, how to get these people in, how to recruit, how to have people understand the pros and cons?
Yeah, exactly. And especially populations that maybe don't have a lot of accessibility to healthcare, or that, like, for example, racial minorities or impoverished populations.
Yeah. No, I must admit, this is probably one of the major challenges now that these two trials are positive. This is the next challenge. So indeed, in our new implementation study in Europe, the 4 in the long run, this is one of the questions. And it's true, the first time we had to submit this project, people say, yeah, but how are we going? How are you going to recruit these people? So that's not an easy answer. But what we will do in Europe, what we will try to do is, for instance, let's say, start off with the correct package in print, correct package online, that you can go online, and a whole sort of more personalized ways of making people aware of this. So probably we're going to make an animation, we're going to make these infographics, we're going to use maybe Facebook, etc., etc. But unfortunately, I don't really have the answer yet. Again, in the trials, we actually did quite a reasonable job. So it's not that in the Nelson trial, we were extremely selective. We really were able to get these people at risk into the trial. So I'm not that pessimistic. But you're right, I don't have the complete answer yet. This is something we have to address in research. Yeah.
Great, thank you. And then Raya's question is next. Raya, would you like to ask your question?
Yeah, thank you. Thank you so much, Dr. de Koning, for the talk. I was wondering if you thought that it may be a good idea to lower the start screening age for women based on the fact that the Nelson trial showed that women have longer preclinical durations.
Yeah, a very good point. But you could also, let's say, go differently. Let's say that because you are able to pick them up earlier, you could already with the same starting age, you are giving more benefits. So you don't necessarily need to go earlier. But now, if we look at lung cancer incidence, it seems, and if you look at these risk calculators and so on, what I hear from my statisticians basically is that if you go below age 50 or so, their risk is still really low. So in general, let's say. So going to a much earlier age, given what we know from smoking and initiation promotion, apparently we need a time lag to get this risk, let's say, in. And so if we would ask someone 40, 45 and make this risk calculator, their risk would maybe be point something. So I think, unfortunately, no, that's probably not the way forward, I think.
Thank you so much.
Great, thank you, Raya. I'll ask a question on the flip side of that. Dr. de Koning, do you think there should be a age cutoff for lung cancer screening on the other end? So for example, in America, it's 77 or 80, but should people get screened when they're 83, 84 still?
So in principle, I am in favor of an upper age limit. In fact, just to let you know, I was summoned, or our state was summoned by the High Court for breast cancer screening and upper age limit, actually. And we defended that at some point, this harm benefit ratio becomes worse. That's why we're doing it. Not because you don't deserve it anymore or whatever. No, it is because for you as a group, it's probably, you're probably worse off if you keep on screening. But that doesn't mean, indeed, we did the analysis that we said 80 is really a good upper age limit still. Mm-hmm. So there is a question now whether you should, for instance, use a questionnaire and say, well, if my remaining life expectancy is, for instance, only 5 years left, or only 5 years left, then maybe I should not come, something like that. There could be some personalization in that, or risk stratification in that. But in principle, given what we know from lung cancer and the incidence, going up to age 80 or so is just fine, even that we know there is a bit more, surgical mortality and so on, even so. Yeah.
Got it. Great, thank you. Rusab has the next question. Rusab, would you like to ask your question?
Yes, doctor. Thank you so much. Thank you for the presentation. And my question was that why was the trial conducted at varying intervals, like 1 year, 3 years, 5.5 years, instead of the consecutive 3 years?
Our trial, you're talking about it with the different intervals?
Yes, sir. Yes, sir.
Yeah. So, so the interesting issue is, of course, we knew lung cancer is rapidly growing. So then you have some limited data that says, well, probably then we should do annual screening or so. So that the NLST had the annual screens was of course very logic. But then you only have the answer what 3 screens with an annual interval will bring. And if you expand your screening over a little bit, you know whether there will be more interval cancer cases, whether you will miss more cases, and you can more, let's say, optimally define or find the best screening interval. So that's what we choose for. And there is a risk, of course, if the 2.5 years, we now know 2.5 years is actually a bit long, but that was only the last screen. If, for instance, we would have started off with 2.5 years, then we wouldn't have found an effect, of course, in our trial. So there's a sort of risk for that. But now we know we have much more information for future policies. So, yeah.
Great, thank you. We have 2 last questions, one from April and one from Evian. April, would you like to ask your question? Okay. So she had a question, which was, is lung cancer relatively more curable cancer compared with other kinds of cancer? So it makes this screening even more important and cost effective. I can answer that. It's much more deadly than other cancers. So, and then Evian, would you like to ask your question?
Yeah, sure. Hi, Dr. de Koning. Thanks for the talk. You alluded to it briefly, but has there been pushback from governments or decision makers on allocating funds to lung cancer screening as opposed to diverting those same funds to further smoking cessation programs? I guess particularly in the countries that are planning on implementing full lung cancer screening.
Yes, I think for sure. So far, I think there are in Europe still not so many governments that, let's say, explicitly state that, but on the background, let's say, there is this issue of, but yeah, it's smoking. Why did they start smoking and whatever? So it is harder to get. It is really harder to get lung cancer screening implemented than than some of the other programs. But nevertheless, I can't imagine that with these two positive trials, and you could say the German one is also positive. I think these things always take time, but I'm actually convinced that that governments will have to do something about it. But it's true, all sorts of arguments are being put on the table. Like, for instance, this is not general screening because it's for a selective risk category. And that's of course not so different from RES, where you just have only age as a risk category, which is what it is. But so I think no, it is really harder. But I'm still quite optimistic. But it's still hard. It is harder. Yeah.
Great. Thank you so much.
Great. Well, thank you, everybody. It's 1 o'clock. Fantastic questions from the audience, and then also Dr. de Koning, again, thank you so much for your time. We know it's getting late over there and your dinner time. So, but we learned so much, and we are really inspired by your work, the work of the Nelson trial. It's really tremendous. It's definitely one of the most impactful studies of the past 20, 30 years. And so thank you very much for talking with us, and hopefully we'll be able to continue learning from you in the future.
Again, thank you very much for the invitation, and this interaction was very nice. So thank you very much.
Great. Thank you. Take care, everybody. Thanks.
Sorry, do you mind if I ask if we can get a copy of the slides somehow?
That's a good question. I'll leave that up to Dr. de Koning.
So I will. There are some slides in it that probably we still want to publish, but we'll arrange something. That's fine. Yes.
That's good.
Thank you so much. They're just so lovely. I wanted a copy of them. That's all.
Yes, of course.
And then Dr. de Koning, if I may just ask like one very last question. Most of the audience is gone, but I was really curious because you can't quite tell by reading the paper. What was it like to perform this study, the Nelson trial, and what's it like to perform a study, in the Netherlands compared to in the U.S.?
Yeah, I don't know whether you want to know this, whether you want to know the answer. No, in general, as you may imagine, I'm already working in the public health field in Europe and the Netherlands for 30 years or so.
Yeah.
And in principle, in Scandinavian countries, UK, the Netherlands, we are, it's now, there's nothing easy, but it is quite doable to do these trials. We have population registries, we have cancer registries, we have informed consent forms, etc. So it has been a tremendous effort, of course, but to some extent, it's easier to do this in Europe than in the US, I think. The NLST is to be applauded for the fact that they managed. Unfortunately, there are many screening trials that didn't work out in the US, and that's not necessarily a logistical thing. It's just simply really more difficult to do.
Yeah. Great. Great. Well, thank you again. Thank you so much for your insight and your time. We really appreciate it.
Very good. Thank you very much.
Great. Thank you. Take care.
Bye. Yeah.
Take care, everyone. Thank you.